So I want to get more into how we treat people in trauma and what are the best ways to do so. So why don't you define for us again, what is trauma as you define it as a professional?
Well, we look at, as a neuropsychologist, we actually do brain imaging generally. And we specifically, we look at a quantitative EEG, and that looks at networks that are then normatively compared across people the same age and the same gender, depending on the database. And there are certain predicted brain networks that can go awry when you're traumatized. So we look at it as a neurological event. Other people may look at interference in attention, nightmares, hair trigger responses to things, depression, anxiety, dissociation. Those are the way the symptoms look on the outside. So that's what it is. And that's different than if somebody's stressed. And technically, according to DSM, you don't even make a PTSD diagnosis for at least a month after the traumatic event.
A brief definition, DSM is
the Diagnostic Statistics Manual that mental health professionals use to bill for insurance.
Got it.
Those are the two ways that you can look at it.
Dr. Petter, what you've just described is two ways of looking at trauma, and you're calling it basically something happening in the brain that is an abnormality. That is not necessarily visible on the outside, but it's definitely happening in the brain. And this is what you study.
Yes.
Okay.
Because usually it is also visible, but since with DSM it's a cluster of symptoms, somebody may or may not have one or the other, and you really want to know what to treat. When you look at the brain, you can see better what's going on.